Jack, you mentioned Keynote 789, which I can't wait to get the results for. One of the biggest issues is patients that are EGFR positive, if they don't have a clinical trial available when the disease progresses on Tagrisso, what do you do? So we all do research and we all want these patients on clinical trial and novel clinical trials, but outside of a clinical trial, an EGFR positive patient who develops or experiences disease progression on Tagrisso, what is the role of adding immunotherapy to chemotherapy? We say single agent immunotherapy is not good or doesn't work all that well in EGFR, but we don't know if immunotherapy with chemotherapy may work. Jack, I'll start with you. What do you do for patients that are EGFR positive if they have disease progression on Tagrisso? What's your chemotherapy regimen? Do you ever add immunotherapy? Do you ever add bevacizumab immunotherapy? How does this play out in your clinic?
I think that there's no way to be dogmatic. Obviously, I share your enthusiasm for Keynote 789 because we're just in a data desert here. This is such a common scenario for which we just struggle with our, grapple with our own judgments. My view is I would generally be inclined to give chemoimmunotherapy here. I just feel that part of it is that I'm a little bit more confident that whatever disappointment we've had with immunotherapy in patients with driver mutations, we can be a little more, I don't know about confident, or I would be more inclined to presume that our disappointment is with monotherapies and that we might be able to get more out of a combination than these sequentially. That said, I definitely don't think that chemo alone is wrong. Yeah. And if any patient had any disinclination or relative contraindication, I wouldn't hesitate to not pursue it. But I lean more toward doing it in the absence of not. And I personally haven't done the bevacizumab. I think that's also reasonable. Just mixed data so far. I personally have no love for the Empower 150 quadruplet with the taxane. It's not, to me, I find the carbo pemetrexed backbone to be just far more patient friendly, hair sparing, things like that. So again, great. I would love to have more data here to tell us what we can all do so that we could reach a hint of a consensus. But I think it's a no man's land, and we're really left with our own best judgments and sharing that with the patient and hearing their perspective.
Yeah, Zosia, your thoughts on this and what you do with patients outside of a clinical trial who develop disease progression on osimertinib that are EGFR positive?
It's a question, like you said, it comes up all the time in the clinic. And I agree. I think we really need more data here. I think one thing that Jack alluded to, I think is an important point, which is that immunotherapy, monotherapy, we know doesn't work well for these patients. And there's certainly an impetus to say, well, what's the best way to try to give these patients access to immunotherapy? And I think that is, one rationale that we sometimes use for combinations. But overall, I would say I'll take kind of a counterpoint here and say that I tend to lean more towards chemotherapy alone, for a couple of reasons. I think one, I'm not a huge fan of the Empower 150 regimen, although Jack, as you alluded to, I think really that data set, that was the study that looked at the 4-drug combination. I've heard it called the kitchen sink approach of carboplatin, paclitaxel, bevacizumab, and atezolizumab. So chemotherapy plus VEGF inhibition plus immunotherapy. And that was compared to chemotherapy alone. And that was one of the only studies in this chemo IO setting that actually included EGFR patients and included only a small number of EGFR patients. But when you looked at that population, there was some benefit. And I think it's important to contrast that with Keynote 189, which is the study that, kind of established carboplatin and pemetrexed or Alimta and pembrolizumab or Keytruda as our standard of care for newly diagnosed patients without driver oncogenes. and is a, that's a regimen that we use all the time, but that study did not include EGFR patients. So I think when we use that regimen, we're kind of extrapolating, but that wasn't a population that was included in the study. So I think, if I were to use chemo IO, I would think about the Empower 150 regimen, but it's a tough, I think it is, in terms of side effects, tougher for patients than carboplatin and pemetrexed. I've had overall good success with carboplatin pemetrexed patients with EGFR mutant cancer specifically, and we've seen with ALK2 actually can, respond very well to chemotherapy. There's always a bit of a hesitation, I think, switching from oral therapy to an IV chemotherapy, but it can be a regimen that's well tolerated, and patients can sometimes be on that for quite a while. I think two other quick points to make is one, again, coming back to this point, which I always come back to, which is this question: if we use the immunotherapy, if we add it into the regimen of, give patients chemo IO, we can't in that situation continue the TKI. For example, if patients are progressing on osimertinib, we know that combining osimertinib with immunotherapy is not a safe combination. We've seen very high rates of pneumonitis when those two are given together. And as I alluded to earlier, we've also seen that when patients get immunotherapy and then get an EGFR inhibitor such as osimertinib after that immunotherapy, there may be higher rates of toxicity, specifically pneumonitis. And I think in my practice, we try to have a lot of clinical trial options for patients, and again, kind of focusing specifically on EGFR positive cancers. Many of the trials will include drugs like osimertinib or other similar drugs, and I worry that if a patient progresses on osimertinib and I give them chemo and immunotherapy as their second treatment, and then later want to put them on trials, there may be some potential for toxicities. Again, we don't know, and it's a patient kind of by patient decision, but that's one of my concerns. And then the last point I'll just briefly make is the issue of brain metastases. So patients who have, osimertinib, Tagrisso, one of its biggest advantages is that it's a drug that's very highly penetrant into the central nervous system. When patients have brain metastases at the time of diagnosis, get treated with Tagrisso, often they can have really good responses in the brain. And what I would say fairly commonly see is that sometimes that cancer in the brain will still be controlled even if other areas of cancer are growing. And in those patients, we don't know, we worry about kind of switching them, stopping the Tagrisso and switching to chemotherapy and immunotherapy, because if the Tagrisso was helping to control that brain disease in the brain, you may run into trouble there. And so sometimes, it's a separate question of whether we give chemo and Tagrisso. That is sometimes something I do, but it's certainly, I worry that giving those patients immunotherapy may limit my ability to reintroduce the Tagrisso if that cancer in the brain were to start to act up again.
Yeah, very nice.
I would just, I'm sorry, just to interject, I totally agree with those points. That's the issue of potentially needing to continue the Tagrisso beyond progression with chemo kind of pushes your hand. And I would choose in someone with active threat of brain involvement, et cetera. Or I've had patients who have a flare after stopping the Tagrisso and go back. And so I think that those are compelling arguments, at least for some of our patients, not using immunotherapy in that setting.
Yeah, very, very nice summary and take from both of you, with highlighting some of the scenarios where it may be useful, some of the challenges.